You mentioned that you do both robotic and open. This isn't the next question here, but I'll ask it. How do you choose the approach for each patient?
This is sort of my big concern in just maybe I'll get into it now is just globally, because I don't think that a robotic RPLND is for everybody. And nor is it for every urologic oncologist out there. I think at the end of the day, the robot is truly just a tool. And so my big fear, and the reason I don't even know that I would love to see robotic RPLND ever as a standard of care, is that while there's a lot of robotic surgeons, there's very few surgeons who specialize in only testicular or germ cell tumors, right? Most of those folks are already been on your podcast or are coming through your podcast. So, there's a handful of folks around the country and in the world. But I do worry about the robotic surgeons out there who one-off, once or twice a year do a robotic RPLND. That's probably not adequate surgery, right? They don't know what the open approach is, adequately. And so when they're trying to mimic something robotically, they're probably doing maybe slightly less than what somebody who also does it open does. And so you really want someone who's doing these operations, who does RPLNDs day in and day out, regardless of technique. With that being said, I think that there is benefit, obviously, in doing it robotically, but again, only as a tool. So if I have a patient who comes to me, I look at their scans, I look at the patient, I make a decision about whether they're going to be eligible for a robotic procedure or not. And actually, currently in my practice, it's only about 40 to 50% of folks who are even eligible for a robotic RPLND that I would offer it for. So I still do almost predominantly open, but when I can do it robotically and safely and adequately, I think it's really, really reasonable. Now, you mentioned the criteria for it, and this has been long-winded, but for me, I try to mimic a lot of what the inclusion criteria have been for primary tumors, say the SEMS trial or the PRIME test trial, for example, for seminoma. So I really try to focus on men who have 3 or less nodes, masses that are less than 3 centimeters or around 3 centimeters. To try and offer it. In the post-chemotherapy setting, I really try to avoid anybody who is obviously a post-chemo seminoma because of the fibrotic or desmoplastic reaction, or even if they have a predominance of seminoma in their tumor.
Okay. Yeah. I think it's great that you, take those considerations. My only experience with doctors other than being a patient is watching Grey's Anatomy. And I think those doctors on there kind of sometimes can be like aggressively wanting to try new things, even though it's a fake thing and it's it's just a show. But, it's good to hear that you're taking considerations right. And not just being. Yeah.
Your point is well taken in that sometimes, someone goes all in on just one thing and or open or robotic. And I don't think that's wrong. The standard of care, so it's said, is still open. But I don't think that it should ever be just all robotic because, listen, if you do a lot of testicular cancer, you're still going to get those folks who are coming to you with big 20, 30 centimeter masses involving multiple other organs. There will never be a replacement for open RPLND. It's those select cases where robot may minimize the recovery time, maybe even preserve the nerve slightly better in certain circumstances. And in those instances, I think that's where it's safe to do the robotic.